पहले रवि के नाम से लॉग इन, नो प्रॉब्लम, absolutely कोई बात नहीं, can change
Good afternoon, everyone. On behalf of Center for Child Health, BLK Super Speciality Hospital, and Central IIP Delhi, I welcome everyone on this lovely afternoon for our next session of BLK TELE, where we will be discussing tonsils and adenoids in children, a rational approach to management. To join us on this panel discussion, we have senior consultant in pediatrics from Max Shalimar Bagh, New Delhi, Dr. Vineet Sehgal. He is a renowned pediatric pulmonologist in Delhi and and he's very dear to my heart as I've learned a lot of things from him. And we welcome you, sir. And we also welcome Dr. Neha Sood, who's a senior consultant in ENT at BLK Hospital, New Delhi. Dr. Ankit Parakh, who's a senior consultant in pediatric pulmonology at BLK-Max Hospital, will be joining us shortly. Meanwhile, I, Dr. Ritika Goyal, pediatric pulmonologist at BLK-Max, will be starting the session. All right. So, adenoid and tonsils in children is a very common problem that we all encounter in a pediatric practice. And we have a lot of diagnostic dilemmas, management dilemmas during our practice, whether we should send the patient for an adenoidectomy or not, when should we send the patient for an adenoidectomy, what is the medical management, for how long can we give it. So to answer all these questions, today we'll be discussing all about adenotonsillar hypertrophy. What are the clinical features of hypertrophy and when to intervene? How do we diagnose it both clinically and what investigations are really necessary? And what is the medical and surgical management of adenotonsillar hypertrophy? Let's start with a case. A 3-year-old boy with Sonipat presented with recurrent episodes of cough and cold with wheezing. And in the interval periods also, he had cough with exertion. He had symptoms on exertion, and there is some cold that was present. Parents said that there is history of snoring and mouth breathing throughout the day. So clearly, our diagnosis based on this history is a multi-trigger wheeze with allergic rhinitis, for which he requires treatment. But my question here is, do you think this child has adenoid hypertrophy? So this question is for you, Vineet, sir.
With the information available, it might not be entirely possible to really comment that if the child has adenoid hypertrophy or not. But yes, the common symptoms of adenoid hypertrophy would commonly overlap those with allergic rhinitis. Though once we have a significant amount of mouth breathing, snoring at night, and maybe history of restless sleep or sleepwalking, sleep talking, those sort of features, then it does suggest presence of additional as a comorbidity, maybe adenoid hypertrophy too. In allergic rhinitis, you would typically have history of a lot of sneezing and watery rhinorrhea, and maybe if it's a bigger child, might complain of itching in the nose or throat, which would take you towards allergic rhinitis. But yes, with this limited information that we have, adenoid hypertrophy is a possibility in this child.
All right, sir. So any child with mouth breathing and snoring, we should raise our antennas, and we must look out for other clinical features of adenoid hypertrophy in a child in a background of asthma and allergic rhinitis. If the mother complains of chronic mouth breathing, nasal congestion, blocked nose, and snoring on most nights, this child may or may not have adenoid hypertrophy, but along with a history suggestive of restless sleep, as sir already mentioned, and recurrent otitis media or recurrent sinusitis, adenoid facies, as shown in this image over here, presence of Denny-Morgan lines, allergic shiners, and a nasal crease. These are all signs of adenoid facies. And if the child has a nasal voice, that is hyponasality, if that is a chronic problem, then yes, these features are suggestive of adenoid hypertrophy. What are the common causes of adenoid hypertrophy in children? Ma'am, Dr. Neha Sood. What are the common causes of adenoid hypertrophy that we see in practice?
Is that question for me?
Yes, ma'am.
Okay, so usually adenoid hypertrophy, when we see in practice, I mean, it usually is along concomitant with a lot of infections in the nose, rhinitis. And most of these children, I would say 90% of the children which we see in our practice have associated allergic rhinitis too, or allergic rhinitis associated with other kind of bronchial allergies, or so like you mentioned, I think these are the two main causes. And most of the children where we will see some kind of adenoid hypertrophy, you will have either infections recurrent or you will have allergies.
Thank you
If
for
I
that.
could just make a point, Ritika, if you could.
Sure, sir.
So, yeah, of course, but what we must bear in mind that there is a certain lymphoid hyperplasia, which is a normal physiological process. So, yeah, you would probably want to differentiate between hyperplasia and hypertrophy, hyperplasia being normal. And for adenoids, yeah, it starts as early as 1 to 2 years of age. The adenoids do get starting enlarged as a normal lymphoid tissue. And it peaks by about 5-6 years of age, maybe, and typically starts kind of regressing after 8-10 years of life. So a little bit of adenoid hyperplasia would be normal. Yeah, hypertrophy leading to clinical significant symptoms, as ma'am has already mentioned. There is a
most of these children do have some, some degree of enlargement of the adenoids, most of these children. So how significant it is to intervene, I think that is what we will talk about. Yes, a little bit of adenoid, if you do an X-ray for every child, you will find a little bit, increase in size of the adenoids or so.
So what really happens is adenoid hypertrophy is because of chronic inflammation of the adenoids. So there is a vicious cycle that forms. A child has some inflammation of the airway, of the nasal passages, leading to adenoid hypertrophy. That leads to blocked nose and accumulation of secretions. And over those secretions, the again has some infection or there is some allergy going on. And the inflammation again increases the size of the adenoids further. So it basically is a vicious cycle that keeps going on and leading to chronic inflammation, which further leads to adenoid hypertrophy. As already mentioned by the seniors, that adenoid hyperplasia is also another entity which we must look out for. In case of adenoid hyperplasia, the size of the adenoids will not be that high that it will have any clinical significance. So the role played by allergy in promoting chronic inflammation of adenoids or tonsillar tissue in children remains unclear as per a few studies. And some studies show that there is a significant correlation between atopy and adenoid hypertrophy. So we don't really know for sure whether it is only atopy that causes adenoid hypertrophy or it is just a state of chronic inflammation. The reason can be atopy or infections. It is seen that children with adenoid hypertrophy with AR have moderate, severe or persistent allergic rhinitis. And the severity to alternata was significantly more frequent in allergic rhinitis patients with adenoid hypertrophy. So at what age adenoids and tonsils are enlarged and hence can create trouble for children? This question is for you, Vineet, sir.
I think I briefly alluded to that earlier. Adenoids would start enlarging as a normal growth pattern, what we call the lymphoid growth curve, by about 2 years of age, and they peak around 5-6 years of age. And typically, as we tell our parents also most of the times, कि 8-10 साल की उम्र में जी घटने लग जाएंगे. So usually, as the graph also shows, by about 7-8 years of age, the adenoid component of the lymphoid tissue does start regressing, while adenoids increase in size slightly later by about 5-6 years of age, and they of course can go on till about adolescence or so. So by 15, 16 years of age, typically you would expect any significant enlargement of the tonsils to have regressed if there is no super added complications or repeated infections or allergies to complicate the matters.
Thank you, sir. As correctly said, as rightly described by sir, adenoids, the natural course of the growth of adenoids is between 0 to 6 years, they start increasing. And then after 12 years, usually the involution of the adenoids take place. How do we evaluate a child with adenoid hypertrophy clinically, and by what do we need to investigate? How do we investigate them? Dr. Neha Sood.
So I think the initial diagnosis is made when you see the child, and immediately as soon as the child walks into your room, if you have a child who has his or her mouth open, and there is a little bit of drooling of saliva even during the day, and usually these children have a lot of rhinitis, so they'll be discharged in the nose also, and sometimes the children will come with secretory otitis media also. So initially, I think just by looking at the child, you will get a feeling that the nose is blocked completely and the mouth is open, and so there is some kind of obstruction in the nose. And in children, this is the most common reason why you will get nasal blockage and rhinitis and mouth breathing and snoring. Second would be the history from parents. And so they will complain that the child is snoring very loudly, or the child is very uncomfortable during sleep, and the child, sometimes parents even tell you that I feel my child is choking at night, and in between there is a small duration when the child is choking at night, and there might be a history of recurrent ear infections. And so clinically, when you've assessed and you think that this might be the cause, and then these days, if we feel the child is cooperative enough, we do a flexible nasopharyngoscopy, and we look for the size of the adenoids even before we get an X-ray done. So I think that is a better form of investigation than a static X-ray, because it gives you a complete overview of the choana and the grade of the adenoid, how much it is blocking the airway. Also, its relation to the eustachian tube can be known, because sometimes, anteriorly, when the adenoids are growing, these children who get eustachian tube blockages, the adenoid is enlarged laterally too, and it's blocking the torus tuberous and the eustachian tube opening there. And so you can have a look at that also.
A very good point there, ma'am, because usually what we see is a lot of patients of adenoid hypertrophy, when they come for first consultation, they have this X-ray with them already there. And yes, we can see a adenoid over here, but there are a lot of fallacies attached with this X-ray. But most importantly, the positioning of the child is very important to actually assess the size of the adenoids. Also, the size of the adenoids that we see on the X-ray does not have a very good correlation with the clinical presentation. Sometimes we see a big adenoid on the X-ray, but the child may not be manifesting symptoms going hand in hand with the X-ray. So X-ray soft tissue neck is not a very good investigation or test to diagnose adenoid hypertrophy, or even check the severity of adenoid hypertrophy. Instead, a nasal endoscopy, or as ma'am said, a nasopharyngoscopy is a better modality. Ma'am, could you describe these images for us?
Yeah, sure. So I think this is the choana. Yeah, this is the choana. And can you see? So how will I be able to point? So I think you will have to place the pointer, because my screen is not shared. So this is this laterally, I think, is the eustachian tube opening, if I'm seeing that correctly, where the pointer is.
Yes.
And this is the nectar septum on the left side. And that's the choana there, and posteriorly you can see the adenoid.
Yeah, and in the second picture, this is the
second picture where you have the star, that is the adenoid.
Yes.
And probably this is the right nasal cavity. This looks like the septum on the right side. So this is grade 4 adenoid, where you cannot see the eustachian tube opening, you cannot see any part of the choana, there is no airway at all. So yeah, this is grade 4.
Ma'am, could you describe the grading? of the adenoid hypertrophy?
So there are multiple classifications, and the easy or the one which we follow is that, if your airway is okay completely, and you can see the eustachian tube opening, you can see the posterior part of the septum, and the adenoid, you can see the adenoid, but it is not obstructing any part. That is, it's a little bit of hypertrophy, but it is not causing obstruction. So that would be grade 1. Grade 2, you will see that a little bit of eustachian tube opening is blocked, or like you have written, it could be it could be 1/3 to half of the choana is blocked, or the easy one is that your eustachian tube opening is blocked, and there is a adenoid hypertrophy, but there is an airway which is present. In grade 3, you cannot see the eustachian tube opening, and airway is even more compromised, and there is a slit-like opening which is there. And grade 4, there is no airway at all. So the posterior end of the septum also is not visible in such patients. So that's grade 4.
All right, thank you, ma'am. So Dr. Ankit has joined us now. So I would hand over the presentation to Ankit, sir.
I think you can continue, Ritika.
All right. So this slide briefly describes what happens in allergic rhinitis and what are basically the complications that we see in allergic rhinitis. So allergic rhinitis leads to tubal dysfunction, as Dr. Neha has already described, that sometimes the adenoid, so what happens is, why do these children have otitis media with effusion repeatedly? It's not only because the adenoid is so big that it blocks the eustachian tube, but also because of chronicity of this problem, that there is tubal dysfunction and there is improper drainage of the secretions. Then a child who has allergic rhinitis is more prone to develop viral infections repeatedly. They have adenoid hypertrophy because of chronic inflammation of the adenoids, leading to obstructive sleep apnea, and they have sinusitis and nasal polyps. How do we diagnose serous otitis media in children? Dr. Neha.
Okay, so a serous otitis media, again, clinically, the parents will say the child is not hearing and there has been a history of rhinitis. And when we do an otoscopy, either we find a grossly retracted eardrum, there is an absent cone of light. Sometimes we even see a air fluid level. So you'll be able to appreciate like a fluid level there. And we send the patient for an impedance audiometry, and usually it is a type B curve, which indicates that there is the pressure is there is fluid inside, or there will be a type C curve which indicates that the pressure is very severely negative and there is some degree of fluid which is present. So these are the two basic things which we have.
All right. So this is the impedance audiometry, where we are seeing, this basically shows all the types of hearing loss. But as Dr. Neha already said, the conductive hearing loss that we see in serous otitis media is the type B1. And so as I already told, I already said that the eustachian tube dysfunction in children, upper respiratory tract infections and AOM, mechanical obstruction because of the hypertrophy, and some craniofacial malformations lead to formation of bacterial biofilms because of the chronic deposition of secretions, immunological factors and allergy, and genetic factors. All these things lead to inflammation, mucin upregulation, viscous fluid in the middle ear, because of the eustachian tube dysfunction, and all of these factors lead to otitis media with diffusion. Okay, when would you suspect obstructive sleep apnea in children? Vineet, sir.
So typically the first complaint that the parents would come with is which we've already discussed, the snoring and the mouth breathing. So that's the commonest complaint they would come to us with. But then when you start digging in, asking more information, then typically they have restless sleep, and parents, the intelligent ones or who've been more observant, they would tell you that it feels as if he's stopped breathing for a while and then startles and gets up and then goes back to sleep again. Usually sleeps with his neck retracted backwards or needs a high pillow to sleep comfortably. So those are the most obvious signs, but or symptoms. But then yes, you would have children who don't get up fresh in the morning because they haven't had restful sleep. Because of that, they are irritable. Some of them present with features of hyperactivity or attention deficit. Poor school performance happens as a secondary consequence. And then, of course, you have things like children start bedwetting all over again. So they develop nocturnal enuresis, they have drooling of saliva from the mouth. And softer signs such as, becoming overweight or being lethargic, some of them can actually have the other end of the spectrum, having failure to thrive. And of course, when you see the child, you have the typical adenoid facies in which, the mouth is kind of hanging open, the face appears elongated, the mandibles appear prominent, and of course, you have the high arched palate and a low lying tongue. So all that goes to give you the diagnosis of adenoid facies. And of course, you could have more sinister things because of a chronic OSA. They could develop pulmonary hypertension. They could have some sort of cardiac muscle hypertrophy. So there's a whole gamut of things. But yes, the commonest would be snoring, mouth breathing, restless sleep, not getting up fresh in the morning, probably impaired school performance.
Thank you, sir. Snoring more than 3 nights in a week. If parents come with this history of snoring more than 3 nights in a week, and with restless sleep, constantly the child is turning around in the bed, or he prefers to sleep with his, as sir already said, arched position or in a prone position, and daytime tiredness. These are some red flags where we need to find out if the child is having any obstructive sleep apnea. One very important point is that size of adenoids and tonsils have a very poor correlation with severity of sleep apnea. Therefore, just by there was a meta-analysis where the correlation, where they tried to correlate the clinical features with where they tried to find out if the clinical features of obstructive sleep apnea that we ask on history, how sensitive and specific they are in diagnosing OSA. And they found that the sensitivity specificity was just moderate. So they don't reliably predict OSA or help in grading the severity. So the gold standard for diagnosing OSA is a sleep study. And so Ankit sir, please tell us in which patients will we do a sleep study, and why do we need a sleep study in these children?
See, as the slide shows, well, all snoring is not pathological, right? So a lot of children, or 10% children would be snoring, or 10% of adults would be snoring. But it does not mean that all these patients have sleep apnea, and it does not mean that all these patients need to be evaluated for a sleep apnea. So 10% of children who snore will have OSA. Then how do you pick them up, right? So as Dr. Ritika has said, the history of snoring is not something which can be really confirmatory. If you have additional features, which we describe as a snore plus, which Dr. Vineet has already defined, so that is basically the entry point for evaluation. We understand that the size of the adenoids and tonsils do not correlate with OSA, which means that if you look at an X-ray, and if you say that this child has a large adenoid and this child needs surgery because this child has OSA, that is again wrong. Looking at tonsils does not tell you whether this child needs a surgery. And a lot of OSA actually happens during REM sleep, and the largest REM phase which we see is actually somewhere like 3 a.m. to 5 a.m. when everyone is asleep. And clinically, you cannot grade severity, and that actually leads us to the point that when do you need a sleep study, or how does a sleep study help? Right. So sleep study is the only confirmatory piece of evidence which you have. So can you go on to the next slide? Yeah, so next slide. So this is what we have actually come to. Now, there might be situations in different parts of the world. So there might be, different set of indications in the American world or Australian world or European world. But we understand that, not all patients who have a persistent snore, who have a very large tonsils and adenoid, and if everything is collecting together and telling us that this child has a sleep apnea with very big tonsils and adenoids, then obviously they don't need a sleep study. You will not, attain much by doing a sleep study in all patients. That is not possible. Now, where do you need to do it? Especially when there's a mismatch, right? So you have small tonsils and adenoids, but the symptoms are very prominent, and you're not sure whether these symptoms are because of sleep apnea. Should you operate this child or not? Or if these are large tonsils having nasal obstruction, but no clear symptoms. So there's a mismatch between symptoms and the findings. The other very important indication is a controversial case. So you have a child, the parents, they have seen 3 ENTs, they have seen 2 pediatricians, 2 say surgery, 3 say no surgery, and you just don't know what's going on. Now, in such situations, and this is a recommendation by the European Respiratory Society, that in such situations, doing a sleep study can be very helpful. It can document a sleep apnea, and it can lead you to an evidence-based diagnosis and further treatment. And sometimes we have situations when post-adenotonsillectomy, patients can have symptoms. They can have persistent snoring, which is there. And in such situations, you also need to do a sleep study because you need to understand what next step is there.
Ankit, I think I would also add, like we usually do in our practice at BLK, that all children below 5 years of age, or very very young children, where 1 or 2 years of age, where we think an adenotonsillectomy, like we've done for children who have been very very young, and there I think for documentation, before you do an adenotonsillectomy, sleep study should be done in very,
Yeah,
very
I agree with you, Dr. Neha, because when it is an obvious age, then everyone understands. But in an infant or in a 2 years old child, when everyone is reluctant, the family is not very clear. We are also not very clear. So I agree in that situation, documenting that this child has a severe sleep apnea, and you've seen the airway, and you're sure that there's no other reason except the tonsils and adenoids. I think in that situation, I agree, sleep study should be done.
Another important cause I feel is that in children with complex OSA, where it's not just the adenoid and tonsils that are causing the obstruction, but there may be other craniofacial abnormalities, children like Down syndrome. In those cases, before we operate, we should do a sleep study to actually know the severity, so that post surgery, if there is any residual OSA, then we have a initial report to compare it with. So I think that is another important indication where we should do a sleep study before operating the child.
Yeah, so that's right. That's right, because in complex OSA, the improvement with adenotonsillectomy, well, it would be there, but the improvement will not be to that extent what happens in children with the simple OSA, because it is multifactorial. So doing a pre and a post study is important, because you need to decide what needs to be done, and you also need to counsel these families very carefully, because sometimes the improvement may not be huge. The improvement might be partial. So in complex OSA, most centers would be doing a sleep study prior to a TNA.
So there are 2 types of polysomnography. So there is a complete pediatric polysomnography, and what we do in BLK, usually in pediatrics, is a pediatric cardiorespiratory sleep study. Dr. Ankit, please explain the difference between the 2 types.
Yeah, so if you look at the gold standard, then it is a full polysomnography. That is what we understand. But doing a full polysomnography sometimes can be very complex, because it takes a lot of time to hook up a child. Having so many channels becomes uncomfortable. And when you actually are interpreting or actually scoring a polysomnography manually, it takes a lot of time. So sometimes it can take approximately an hour or 2, even longer sometimes in these situations. Now, this is more of the American way or the Australian way of doing it. But if you're looking at sleep disordered breathing, which is the most common subtype which you see, then cardiorespiratory studies are something which suffices in most of these patients. So that is the European way of doing it. And that is the way we do it because, we have got a lot of training from centers in London. Right. So what they do is that they would not use a EEG, EOG, and chin EMG, and they would use thoracic and abdominal bands. They will use a microphone, an ECG, an SpO2, and a CO2, but it is still a in-lab study. So you still have the patient in the lab. You're not doing it at home, but you're doing a limited channel study. The benefit is that you can hook up the patient in 5 minutes. You can score the study in around 15-20 minutes. And it becomes very comfortable. And still the amount of information which you get on the respiratory part is almost equivalent. But obviously, we can do a full polysomnography at any point of time because it is a level 1 sleep lab. So if you have a patient where you want to, study the sleep architecture, supposedly a patient has a complex parasomnia or has a doubtful seizure or something like that, then obviously you can always do a full polysomnography.
So to summarize, we usually do a cardiorespiratory sleep study where we're suspecting a obstructive sleep apnea. But if we have a child with parasomnias or other sleep disordered breathing, or we're suspecting seizures where we need a EEG as well, then we can do a polysomnography in such cases. So this is a trace of sleep apnea. Dr. Ankit, please explain the trace to us.
Yeah, so this is an epoch of a cardiorespiratory study. The uppermost channel is the SpO2, right? Below you find nasal flows, and below that you will find thoracic and the abdominal bands. And on the nasal flows, we have marked obstructive apneas labeled as OAs, right? So during these episodes, the nasal flow tends to be less than 90%. You can see simultaneously that the child is having desaturation. And if you look at the respiratory effort bands, they appear to be out of sync. So there is movement of the thorax and the abdomen, but it is not in sync. So that is what happens in an obstructive apnea. The child struggles to breathe. On the contrary, if it is a central apnea, then you will also find that the thoracic and the abdominal bands will not show any breathing movements.
I know why the pointer is not okay. Yeah. So basically, these are the desaturations, which is more than 3%. This is the nasal flow, which is absent. And these are the thoracic and abdominal bands that are moving. So the thoracic and abdominal bands are moving, but there's no nasal flow. And there is a desaturation of more than 3%. So this is an obstructive apnea. And here, as you can see, there is a loud snore throughout the study, as we can see on here on this. And then the desaturation of more than 3% from 98 to 95%, preceding which there is some altered flow in the nasal on the nasal sensor, and the thoracic and abdominal bands are moving. So in this patient, the apnea-hypopnea index was 40.2, which is high. The oxygen desaturation index was 48.1 per hour with the lowest SpO2 or nadir of 50% and a loud snore throughout the study. So this is a trace of a severe OSA. Sir, I would like to ask Vineet sir and Ankit sir both on their thoughts about home sleep study in children. So Vineet sir first.
If allowed, I will give it a pass because frankly, whenever I run into these problems, you are the guys I send the child to. I think just the basic thing that I recommend in the clinic is for the parents to, just film a video of the child while he's sleeping and when they feel that the child has problems. So usually that gives a good indication of what is actually happening, because if they kind of click the video well, you can see that the child is getting restless, is having altered postures, maybe the abdomen is moving but the chest is not moving. And of course, if the more intelligent ones can hook up a pulse oximeter, because everybody has a pulse oximeter at home nowadays, so if they can kind of read out the saturations at that time, that gives us a fair idea, and that at least pushes me to send the child for a formal sleep testing. So beyond that, I mean, I would probably tester Ankit to take over the child and do the needful.
Yes, sir. Ankit, sir. What are the main problems with the home sleep study in children? Dr. Ankit.
I think you lost connection.
Mm.
You can carry on.
I feel that main problem with the home sleep study is that that we don't have although the equipment is there, most of the time the sensors, if they are displaced, then the technician might not know. There is no audio video recording in a home sleep study usually. So as sir already rightly said, that the tracing that we see on the sleep study report, the tracing might show that the child is in a REM sleep with a lot of movement, but actually what is happening is the child is taking a turn, and it is not really so. The scoring of a REM and a non-REM sleep in a home sleep study is not very reliable. Secondly, the sensors are, if the sensors are displaced and the study is going on, then we would not know about it when we are interpreting it. The main difference between a pediatric and an adult study is that in an adult study, they don't need to score it as vigilantly as us, because the systems, the machine, the softwares are calibrated as per the adult normal data, and even the AI generated report is reliable most of the times. But in a pediatric study, we need to score the entire sleep study record ourselves, and if we don't have an audio video recording and if we don't have reliable sensors, then the degree of OSA that we find on the report may not be as reliable. So in children, it is always better to do a in hospital or a in lab study, so that we get a more reliable report. So, Vineet, so what is the medical treatment of adenoid hypertrophy? When should we treat?
Yeah, so I mean, all of us do try medical treatment before, raising our hand and handing over the child to our ENT colleague. So again, with adenoid hypertrophy, you have two elements. You have the infective element. There's an element of infection going on, and of course, there is the element of obstruction going on. So, of course, if you have sign symptoms of a chronic, rhinosinusitis, or for that matter, even an acute rhinosinusitis, remember there is a now dead space around the enlarged adenoids with very poor ventilation. So there is a lot of subclinical infection persisting, which leads to low-grade symptoms. So there is always a case for a prolonged course of antibiotics to at least once clear up that airway. So typically you would use a coamoxiclav for it, and it's actually a longer duration, so maybe 2 to maybe 4 weeks also, if it's very chronic symptoms, to eradicate the infection and see how the child does. Simultaneously, probably you would do a little bit of nasal douching with the saline again to get the secretions out, and maybe decongestant drops if the child is having difficulty in breathing. And of course, as a next step, because it's commonly coexists with allergic rhinitis, once you're sure you've treated the infection, then we do use intranasal corticosteroids, and typically we would use them for about 12 weeks. And in, I would say, a substantial percentage of children, I wouldn't hazard an exact number, but a substantial number of patients do well once you give them intranasal corticosteroids. One, the allergic component dies down, and probably there is some reduction in the adenoid volume as such. So the children definitely become comfortable. So, taking account into this whole process, we do this over 3 to 6 months. And if the child improves on our medical management, well and good. Otherwise, of course, we call in our ENT colleagues to, do an endoscopy and then, kind of take a call on when to intervene surgically.
Yes. Very true, sir. So, when do we treat it? If we have a child with mild obstructive sleep apnea and associated allergic rhinitis, we treat with intranasal corticosteroids, either a mometasone or a fluticasone, plus minus montelukast. However, now montelukast has a warning that it causes behavioral problems, so we try to avoid it. But yes, intranasal steroids are the mainstay. We give it for 3 to 6 months, as sir has already told us, and we reassess after 3 to 6 months. And even in our experience, the children do respond to intranasal steroids, and in most of the patients, we see an improvement, and we might not need to send them for a adenoidectomy. So, what are the evidence-based recommendations for adenotonsillectomy, Dr. Neha?
So, now I think in the last decade, the indications for removing adenoids and tonsils has changed completely. I think in my own practice only, initially we used to be doing so many adenotonsillectomies, and now that is one of the rarest surgery we do. And so now I think for the children who have tonsillar infections, so what is recommended is that at least in the past year they should have at least 7 episodes of tonsillar infections, and the year prior more than 5 episodes, and in the past 3 years, the last 3 years, they should have at least 3 to 5 infections. So if that is documented by a clinician and a swab has been taken which is positive with cervical lymphadenopathy, so then only we recommend tonsillectomy, or a child who has either proven OSA or clinically, it is obstructive sleep apnea. These are the 2 main indications now when tonsillectomy is advised. Unfortunately, in our country, most of the throat infections come to us as tonsillitis, which is not proven. So, in our practice here now, I've started doing that. At least when I see a tonsillar infection myself, because every parent thinks that a throat infection or a is tonsillitis, and generally that is the way children come to us also, even from the general practitioners or sometimes pediatricians who have written tonsillitis, but it is actually not proven tonsillitis. So so these are the 2 main indications when we are doing adenotonsillectomy.
Yeah, so main indications for adenotonsillectomy, recurrent episodes of tonsillitis or adenoiditis, as ma'am already said, more than 3 in a year. Child with otitis media with effusion or recurrent acute otitis media which needs antibiotics. That is another indication. Obstructive sleep apnea, moderate to severe obstructive sleep apnea is a clear indication of adenoidectomy. Another is malocclusion, craniofacial deformities, and basically malocclusion and high arched palate, the facial changes that take place as a result of adenoid hypertrophy. If a child has that, then that is another indication for doing a adenotonsillectomy. Ma'am, in your experience, do you see any difference in children you do only adenoidectomy and children who undergo TNA both surgeries? Is there a...
In OSA, yes, there is, it is documented that most of the children who are having obstructive sleep apnea, their adenotonsillectomy together has proven to have better results. Even if your adenoid size is not grade 4, is proven to have a better outcome than tonsillectomy or adenoidectomy alone.
So is adenotonsillectomy a cure for OSA? And what is the incidence and severity of residual OSA? Dr. Neha.
I think that depends on the cause for OSA, I think.
Yeah.
So if the cause is only adenoid and tonsillar hypertrophy with no other problem, even if the child is obese,
Mm.
then also that will not lead to complete,
Yeah.
cure for the symptoms, or uh, the symptoms will not go away completely. And in cases of complex OSA, again, there are multiple factors. So it is very important to evaluate properly and know what is a causative factor before we do any interventions, especially surgical intervention. And once we've evaluated that this is the only cause, then only you can tell the parents. And there also, I think you have to counsel them in today's time that allergic rhinitis still will happen. It is only the obstructive part which will be taken care of.
Exactly, that's a very important point. Usually, what we see is that once the adenoidectomy is done, parents stop their treatment for allergic rhinitis. So it should be very clear that adenoidectomy is not the treatment of allergic rhinitis. The allergies are going to remain. It's just the obstruction that we are relieving by doing the surgery. So the children should be on treatment for allergic rhinitis or the intranasal steroids to reduce the chances of recurrence of adenoid hypertrophy. We'll be coming to recurrence rate as well.
Parents come to us that my child is having recurrent colds. So somebody has advised me adenoidectomy, you remove the adenoids and the colds will go away. So I have seen parents come to me ki surgery kar do.
Yeah, so that should be very clearly conveyed to the
There is
parents.
absolutely no indication to do adenoid surgery. I mean, you treat the allergies in the child. If you ask them when you give the medication, is the child better? Tab theek ho jata hai. So you need to counsel them properly the difference between an enlarged adenoid and an allergic problem.
So if we would want to enumerate the risk factors for a residual OSA in a child undergoing adenoidectomy, what will be the risk factors, Ankit sir?
Yeah, so see, the world now believes that adenotonsillectomy may not be a complete cure for OSA, even in children who have a simple OSA, right? There's always uh, an incidence of having a residual sleep apnea, which might be variable in different studies, but approximately 15-20% of patients can still have a residual OSA, but it markedly reduces the apnea hypopnea index. So if the pre-surgery apnea hypopnea index was 30 and it comes now to supposedly 6, then obviously the severity reduces markedly. Right. So that is what we are talking about. But a lot of data is now there, especially from the American countries, that the severity definitely reduces, but it may not be a complete cure. So we are not trying to say that all patients after surgery should undergo a sleep study. No, that is not what we are trying to say. We are just trying to say that if you have a child who has a simple OSA, who does not seem to have any other problem, then you need to at least follow up these patients clinically and look at symptoms. Now, if they still seem to have symptoms which are persisting beyond 6 to 8 weeks of surgery, then these are children who might be having a residual OSA and might require a repeat sleep study to document and see what needs to be done. Now, the scenario might be different in children who have a complex OSA because we already know that the cause of sleep apnea is multifactorial. It is not just the adenoid and the tonsil. So you need to do a sleep study prior to surgery, counsel these patients properly that the relief in symptoms will be partial. Now, how much will it be there? Will it be like 50% improvement or 70% improvement is sometimes difficult to say. These children would be followed up clinically, you do a repeat study and then decide whether this child actually requires a CPAP.
Right. So children with complex OSA with craniofacial abnormalities, obese children, children with a severe AHI to start with more than 30. These are some even infants and children less than 3 years of age are also at risk of having residual OSA. These are some of the patients where you will counsel the parents before the surgery that there is an increased risk of having residual OSA post-surgery. So let's discuss another case. It's a 12-year-old boy with snoring, observed gasps and pauses, and adenotonsillar hypertrophy. ENT advised them a TNA surgery and he underwent that. Post-op, the child still continued to have heavy snoring, and his polysomnogram showed a AHI of 27.2, which is high, it is moderate OSA, ODI, oxygen desaturation index of 36.5, with the nadir of 80% and mean SpO2 of 91.5%. So, Ankit, so please interpret this polysomnogram report.
Yeah, so as I said, this child is a post-adenotonsillectomy child and still has a heavy snoring. And we have done a polyraphy or a cardiorespiratory study 6 to 8 weeks post-surgery, right? And it still shows an AHI which is very high, which is 27. And these are situations when you need additional form of treatment. So this child was started on a CPAP and thereafter remained well.
So if we describe a rough approach to obstructive sleep apnea, first we need to find out whether it is a mild, that is AHI less than 5, or moderate to severe obstructive sleep apnea. In case of mild obstructive sleep apnea, medical management and follow-up usually suffices, and we give them a medical treatment trial of 3 to 6 months and then reassess. But in a child with moderate to severe OSA is a clear indication for doing a TNA surgery. And if the child does not have, if the cause of OSA is not adenotonsillar hypertrophy or some other malformation, in those children we do a consider putting them on CPAP or consider other surgical options. We do repeat a sleep study after the TNA surgery, especially in cases of complex OSA or in children who are symptomatic after the surgery. And depending on what we get, whether it is mild or moderate, we continue with the medical management. So we'll discuss complex OSA in short. What is complex OSA? Complex OSA is a multi-level obstruction. That is obstruction not only at the level of the adenoids, but also at the level of tonsils. There may be a large tongue which could be falling back. There could be retrognathia. There could be a long palate. So other facial deformities. There could be inferior turbinate hypertrophy. So all of these individually cause obstructive sleep apnea, and if they're all present at once, then also this is what we call is a complex OSA. What are the causes of complex OSA? As described in this slide, there can be neuromuscular disorders, genetic syndromes like craniofacial syndromes, Down syndrome, obesity-related syndromes like Prader-Willi and Bardet-Biedl, achondroplasia, mucopolysaccharidosis, and other high-risk groups are children with chronic lung disease, sickle cell disease, or tracheobronchomalacia. These are all children who are at risk of having complex OSA, which is not related to just adenoid or tonsillar hypertrophy. What is the role of adenoid and tonsillar hypertrophy in complex OSA? Ankit, sir.
Yeah, so I think we have already talked about this, that the primary treatment for OSA in children, even if it is a complex OSA, still remains as adenotonsillectomy, because you have to relieve the obstruction first before prior to using a CPAP. There could be situations when your ENT colleagues say that they are very small in size and it will not help. That is a different situation. But if the tonsils and adenoids are enlarged, then they need to be removed. The parents need to be counseled that the relief in symptoms could be mild to moderate, and you need to follow them up very carefully and do a sleep study after around 6 to 8 weeks and decide whether they actually need additional treatment in the form of a CPAP.
At what age can adenotonsillectomy be performed, Dr. Neha?
So we've done as young as like 2 years also, but normally generally recommended age is 5 years of age. But earlier than that, I think you should have a very strong indication like a severe form of obstructive sleep apnea. And that is the only indication in doing adenotonsillectomy for such young children of more than 1 year or below 5 years, I think.
And is there an upper limit as well where we, at what age we say that we don't need to do a adenotonsillectomy? Is there an upper age limit as well?
We have removed adenoids in adults also.
Hmm.
We have removed adenoids. There are patients where we have done here, and they have had very severe allergic rhinitis with nasal polyps and a huge adenoid at the age of like 25 also. And then there to once you remove the polyps and everything, and if you leave that adenoid tissue there, the nasal obstruction will not go away. So we have very rarely, but it has happened. So I think it's only when if there are adenoids which you see and they are asymptomatic and patient is not having any problem, nothing.
All right. So another case is a 2-year-old boy, and this is what we hear when he's sleeping.
Audio on that, but yeah, you can.
What do you know?
I hope the sounds were audible to everyone. I'll play it again. So we can see that here the child is. So Vineet sir, can you describe these sounds? Whether it is snoring, it is a stutter, what exactly is happening?
Frankly, I couldn't hear the sound, but I could just see the child is struggling to breathe. You should comment on that. I frankly couldn't hear much.
Yes, so the child was struggling to breathe. Sounds were not really snoring, but they were actually a stutter. So stutter is when the obstruction is at the level of the nasopharynx or the oropharynx. That's where we hear a stutter kind of a sound and not a stridor kind of a sound. And there is this child had snoring and mouth breathing since 6 months and difficulty in breathing since 2 months. And so when we did the echo of this patient, there was severe pulmonary artery hypertension, which we could figure out on echocardiogram, which is a complication of obstructive sleep apnea as well. And we did a bronchoscopy. This is the bronchoscopy video where we can see that there is severe obstruction in the nasal cavity. Dr. Neha, can you describe these findings as the video is going on?
These two projections which you see on the side, those are the adenoids.
Yeah.
And yeah, so as you can see, as the child is in a lying down position and trying to breathe, both the tonsils are coming and approximating together. Yes. And that is what happens when the child is sleeping and the airway completely closes, and that's when the snoring sound comes. Or the child, when they completely close and the child cannot breathe for a few seconds, and that is the stage of the apnea when there is no air which is being inhaled by the child. So this is what the picture grossly is showing.
Yes, so this is complete obstruction of the airway in sleep, where the tonsils and the adenoids, everything is falling on itself and closing the glottis. So this child was started on a nasal CPAP with a pediatric wisp mask. He was operated after a week and kept in PICU, and he was discharged on CPAP. We are yet to see him on follow-up. But this is how bronchoscopy helps in cases of obstructive sleep apnea. Another case of a 17-year-old boy with snoring since 3 years, excessive daytime sleepiness since last 6 months. He's studying for medical entrance exam and has poor sleep hygiene. So, Ankit, how will we, first of all, why do you think that his sleep problems are related to his sleep pattern, and how will we treat him?
Yeah, so children or adolescents who have excessive daytime somnolence, you can have many causes. And the first cause obviously would be related to a poor sleep hygiene, their sleep cycle, whether they're actually having 6 to 8 hours of sleep or not. So all these things need to be, looked at, right? So that is the most common cause of a daytime sleepiness. So when we evaluated this child, we actually made a sleep diary first to understand what is the sleep pattern. We counseled him saying that, you need to have an adequate sleep to understand whether the daytime symptoms are because of a short sleep, or is it actually related to a poor quality of sleep. Right. So when we followed this child up after around 2 to 3 weeks, we realized that the sleep diary shows an adequate duration of sleep, but still the child was having an excessive daytime sleepiness. And then we went ahead to do a sleep study to understand, what is the cause of this daytime sleepiness. And we realized that this child has a severe sleep apnea. So the AHI was more than 10. Uh, Now, why is this child having an OSA? Was the next question. Should we just put this child on a CPAP? This child is around 17 years of age. But we thought that, you can't just assume that this child does not have a large adenoid, right? So let's first do a nasal endoscopy. So this child was referred to Dr. Neha, and we actually found that this child has large adenoids, which is leading to the problems.
So, Dr. Neha, please tell us in brief, since we are running out of time. Can you tell us in brief how do we do the adenotonsillectomy? What is the patient counseling? What is the recovery time in brief, please?
So I think counseling is very important, and telling the parents what to expect during surgery and after surgery is very, very important in all these patients, because doing surgery is like a half an hour, 1 hour job, and then the outcome has to be explained, and post-operative recovery period also needs to be explained to these patients. So it is, most of these children we admit for usually 24 hours. So we need to watch for any signs of bleeding for the first 24 hours. And in children who are below 5 years and we have severe OSA, or children who are obese, we advise a 1-day PICU stay. Because sometimes when we do the surgery, especially in obese children, and the child is extubated, there is a lot of edema there, and the child can have symptoms like OSA, and the child might require CPAP for at least 24 hours immediately post operatively, or the child needs observation for 24 hours. So that needs to be counseled, especially in children who are obese or who have other comorbidities like Downs. So that counseling is required. So minimum 24 hours and 1-day PICU stay in cases where we are expecting some kind of problem post-operatively. Coming to how do we do the adenotonsillectomy, the best way in today's time is coblation. We started with curettage initially. Now I don't remember when I used the curette last. So then we went to micro debrider, which is an endoscopic guided procedure again. But again, it is a good procedure, but there is bleeding. And but in coblation, the advantage is that you can ablate and coagulate at the same time. So the chances of bleeding are very less. Even during the surgery, the blood loss is minimal. So that is what we prefer these days.
And what are the chances of recurrence of adenoids after adenotonsillectomy? Because we have less time, I think I just answered it.
I think a multifactorial, again, children who have very high allergies and they are very highly allergic, they, I think, will have more chances of recurrence, and who do not take medication or who do not have regular follow-ups. But especially children who have high rates of allergic rhinitis have high chances of recurrence or recurrent infections.
And the recurrence risk of adenoids after surgery ranges from 2 to 8% in children. And the most common cause, as Neha rightly said, is coexisting allergic rhinitis and asthma, which is not treated adequately. In these children, there is chance of recurrence of adenoid hypertrophy. With that, I would like to end this session, and thank you so much to all the panelists. Thank you so much, Vineet sir. Thank you so much, Dr. Neha, and Dr. Ankit, who could make it right in time. And thank you so much to all the organizers and IP Central Delhi for providing this platform to conduct these discussions.
Thank you. Thank you.
With that, I would like to end this session of Telepedes, and we'll be coming back with new topics, more interesting discussions in time to come. Thank you so much. Have a lovely afternoon.
Goodbye. Thank you.
Goodbye.
Okay, thank you.
Thank you.